right, good afternoon, everyone. Thank you for joining us. Today, we are joined by Janice Walters from the Rural Health Redesign Center. They are actually the Rural Emergency Hospital TA grantee, technical assistance grantee. And so if you recall, last fall or in December, we hosted a couple webinars about what is the Rural Emergency Hospital designation, next steps, just more information. We mentioned, I believe on our December call, that there was a TA grantee. And so this webinar today is really just to provide an introduction to the services and technical assistance they provide, as well as ask any questions, answer any questions y'all might have. We will be recording today's session and getting it uploaded to our YouTube channel. And so please let me know if you have any questions. If you are watching this recording and if you have any questions, please feel free to reach out to us. With that said, Janice, I will turn it over to you.
Great. Thank you, Lara. And thank you for having us here. So certainly my goal today is to introduce you to the RHRCO as well as the Rural Emergency Hospital Technical Assistance Center, as Lara has already mentioned. Certainly my goals are to provide a high-level overview of what the REH-CMS designation is and what it is not. Also want to provide insight into the technical assistance services that the Rural Emergency Hospital Technical Assistance Center is prepared to offer to interested organizations in terms of those that are interested in learning more about what it is, the services we provide and our approach of how we're doing our work. Certainly provide insight into a timeline of activities, as well as then answer any questions that you folks might have and certainly my goal for today is to make this meaningful to all of you that might be listening. So really just a brief overview of who we are as the Rural Health Redesign Center organization. We are Pennsylvania based. We were established in May of 2020 for the purpose of advancing rural healthcare both within Pennsylvania and beyond. And we do operate as a 501c3 not-for-profit organization. Certainly one of the programs that we do manage is the Pennsylvania Rural Health Model, which is the CMMI demonstration project specific to an alternative payment arrangements for rural hospitals. And that was the primary work that our organization was doing up until recently when we were successfully awarded the Rural Emergency Hospital Technical Assistance Grant, as well as another program outside the walls of Pennsylvania. So certainly our mission overall is to really protect and promote access to high quality healthcare for rural residents. And really our vision is to help rural communities thrive through improved health. So certainly the Rural Emergency Hospital Technical Assistance Center and the work that we are doing aligns with our mission and vision, as we certainly know that rural hospitals across the country are in crisis, and the Rural Emergency Hospital designation may be a path forward for some. We certainly recognize that it will not be a solution for everyone, but certainly want to walk with hospitals as they explore this opportunity to see if it could be a right fit or not. So again, who is the Rural Emergency Hospital Technical Assistance Center? It is a collaboration of 3 different organizations. Certainly we, the Rural Health Redesign Center, are the lead organization, leading the work specific to technical assistance, putting all of the processes together to basically walk with folks on a journey as it relates to understanding, again, what the designation is, what it is not, the pros and cons, and really providing hopefully information to all of you that will lead you to a decision of whether it's right for your community or not. So again, we are the lead organization, coordinating all of the work, but we do have technical partners along the way. Mathematica is our partner specific to a lot of the financial modeling. And understanding what the new financial arrangement could provide, what it means. Does the math work for rural hospitals that might be considering this? And then we also have a clinical group that we are working with to provide insight into potentially alternative structures and insights from a clinical perspective, and really into maybe niche ways of providing care that might be appropriate within the new rural emergency hospital structure. I will say just early on that, our proposal was based on the preliminary rules and what we thought the final rules would contain specific to a transition, a formal documented transition plan. The final regs were did not require that, and therefore, some of what we might be prepared to provide to hospitals might not actually be needed. But certainly, we have that skill set and competencies within the team that we've pulled together to help not only with the financial assessments but also strategic planning. So, who we are, we're a group of three different organizations that we're leveraging a lot of collective experience and a commitment to improving the lives within rural communities. And we do believe we are well equipped to provide the technical services, given the award that we did receive from HRSA. So, how do we provide our approach to our work? Certainly is one of cooperation and collaboration. And so, our goal is to work collaboratively with HRSA as well as state offices of rural health and flex coordinators across the country to help identify and work with interested hospitals. And so, again, doing so in the work of collaboration, and thankful we've already had a couple conversations with Lara, and certainly me being here today is part of our collaborative approach to really work in partnership with other organizations and really walk with hospitals as well as flex coordinators and state offices of rural health on this journey. We also commit to respond quickly to those folks that do make outreach to us. We do view ourselves as a service organization, and so want to make sure that we're responsive to anyone that would reach out to us through our support line. We do commit to get timely response and answer questions as quickly as possible. We do provide education and also perform an initial intake assessment. So, part of our work is to make sure that there's general education made available in terms of what the designation is, but then also individual hospital assessments and really, again, walking on that journey with the hospital leaders as well as community leaders. And so, through initial intake assessments, we do gather information that sets us up then to provide more individual one-on-one coaching and expertise based on what we're learning from your organization. We do have a lot of rural, or I should say, staff on our team that have a lot of rural relevant experience. Again, we want to make sure that we as an organization understand what all of the rural hospital leaders are dealing with. And so therefore felt it was very important that we brought onto our team folks that have rural relevant experience. So I was a former finance leader at a critical access hospital here in the state of Pennsylvania. I like to say it was a small health system as we served a 4-county area. We had 10 provider-based rural health clinics as well as specialty clinics that were structured as option 2 provider-based clinics. So certainly understand that, and in my role, I oversaw all of that as well as the practice management, running the clinics, as well as serving as the finance lead for the rural health system. So again, from myself as well as other folks that have been added to the team, really are rural subject matter experts given our lived experience in rural communities leading rural hospitals. I've also already mentioned this, but we do perform financial assessments, identifying what the new RH designation could look like from a financial perspective. I'm a firm believer if the math doesn't work, it doesn't provide a more financially viable path forward, it's probably not something that our rural hospitals can consider. And so we really do start with education and then financial assessment. As I already mentioned, we do also offer strategic planning support. If it's determined that this might make sense, work with hospitals that are interested from a strategic planning perspective to make sure that, if there's changes that are needed to be made in order to make the math work, all of that you have strategy partners to assist you along the way, and then also providing insight into the application process and what to expect. So that's really the approach to our work in terms of as we, as an organization, make outreach and identify interested hospitals. This is how we have planned to do our work. As part of the session today, I did want to provide some insights. We did host our first public session as it related to rural emergency hospital education last week. And so bringing some of that information into the presentation today, that recording as well as the slide deck from last week is available on our rhrco.org SharePoint site, excuse me, website, not SharePoint, rhrco.org website if you're interested. And I also am providing that information later in the slide deck as well. But again, just repeating some of the information that might have been heard as part of the session last week in terms of what is the Rural Emergency Hospital designation. And it's a new Medicare provider type that was established on December 27th, 2020, to be effective January 1st, 2023. So this is a new designation that has just been made available to rural hospitals to consider. And really the overarching goals is to avert potential closures of rural hospitals, recognizing that the current fee-for-service reimbursement, given the demographics of many rural populations, is not providing a viable path forward. This new designation is the hopes that it could provide a viable path forward for some rural hospitals. So really it's to avert, potential closures of rural hospitals, to allow for the continued offering of essential services for rural communities, such as emergency services, as well as laboratory and imaging services, and then really to advance rural health equity in rural communities. So, with rural hospitals closing across the country, there's data to show, at least in the state of Pennsylvania, and I'm sure this is, true of all rural communities across the country. Rural communities do tend to be older and sicker. And so certainly with the potential closure of rural hospitals, we know those data indicators, health indicators would be exacerbated. So again, in the spirit of equity, trying to make sure that our rural hospitals do stay open to advance health equity in rural communities. It is really the overarching goals of the Rural Emergency Hospital designation. So specific to eligibility, there are certain eligibility requirements that a hospital must meet in order to convert to a rural emergency hospital. Certainly, they must be either currently licensed as a critical access hospital or a rural prospective payment system hospital with fewer than 50 beds. And we will share with you the actual calculation on the next slide in terms of determining if you meet that 50-bed requirement or not. There's a specific calculation, and we do share that with you. You must be enrolled in Medicare. So you have to be Medicare certified and enrolled in Medicare in order to make the conversion to an REH. You also have to have an established transfer agreement with a level 1 or level 2 trauma center that must be in place prior to making the application to become an REH. Also, you will need to meet state licensure requirements for the rural emergency hospital. So while it's our understanding that there is no CMS certification requirement, there is a state licensure requirement. And so a lot of this, what that looks like, will actually be determined at the state level, but certainly wanting to make sure all of you are aware that there is a state component to this. I do not believe Oklahoma, I could be wrong, but there's only a few states, in the country that are already prepped for this. Lara, can you remind me if Oklahoma is one of those?
We're partially there. We have emergency hospital as a designation option. It just doesn't meet the current definition with services available as the rural emergency hospital. And so I know our hospital association is working with our state Department of Health to get that updated. So those will align in the future.
Great, thank you. So there again, a lot of this does come back to the state requirements, but it sounds like Oklahoma is well on its way to getting there. That if there are hospitals interested in converting, that hopefully the state will have its licensure and regulatory environment prepared for that near future. You do have to meet the requirements of a staffed emergency department. We'll get into conditions of participation at a high level in forthcoming slides. Certainly need to meet certain staffing, training, and certification requirements. And then, as I've mentioned, there are specific conditions of participation specific to the rural emergency hospital that must be met. And again, we'll show a high level comparative in forthcoming slides. Specific to the bed count calculation, again, there is a specific calculation. It is actually following the calculation for the Medicare dependent hospitals. And so providing this to you, it's not based on licensed beds, but really based on available beds. So it's the number of available bed days during the most recent cost reporting period divided by the number of days in the most recent cost reporting period. And it is our understanding that in order to currently qualify for the Royal Emergency Hospital designation, it would have been the cost report right prior or the most current cost report as it relates to that December 27th, 2020 date. And so this is a point in time as it stands now that a hospital has to meet this bed count in order to qualify. And certainly, have captured that as a potential barrier, but our read of the current statute is tied to the specific date of when this act was passed, which was December 27th, 2020. So there's also certain service provision requirements that REHs must meet. And so an REH must be able to provide 24/7 emergency and observation services. So I know we've had outreach from some organizations that say, they don't currently staff, 24/7 emergency. But in order to, be an REH, you must provide 24/7 emergency and observation services. Also, you have to offer diagnostic lab and radiological services, pharmacy, drug storage area, and have to have discharge planning overseen by a qualified professional. We also need to meet average length of stay requirements. And so this is really based on an annual average length of stay per patient for the Rural Emergency Hospital services. And that annual average length of stay cannot exceed 24 hours. So certainly, CMS does recognize that there's some patients might stay longer than the 24 hours. Some will certainly be shorter, but that is really a calculation that is calculated based on the time of registration. So the patient's length of stay begins at the time of registration or check-in or triage of the patient, whichever occurs first, and then ends upon the discharge from the Rural Emergency Hospital. And again, distinct part skilled nursing facilities are not subject to that 24-hour annual average length of stay, but certainly that is, being able to calculate this is a technical requirement that folks considering this designation would need to ensure that their EMR systems, their registration systems, all of that are set to actually be able to calculate this. Beginning with the patient's registration to when discharge actually occurs and the timestamp that discharge occurs in the system. So there is flexibility as it relates to that annual average length of stay per patient requirement, and certainly the guidance that we've read within the final regs is to the extent that a patient's length of stay would be longer than that 24 hours, documentation in the medical record of why would be very important. So whether that's, inability to transfer to the next level of care, transport services not available, inclement weather, whatever that reason might be, hospitals would be encouraged to make sure that that is well documented in the medical record. Certainly, there are other services that REHs can provide, but are not required. And so certainly if there's other types of outpatient department services, including behavioral health, radiology, laboratory, telehealth, and outpatient rehab, certainly you are able to do that. Specific to the labs and imaging required, that's really specific to emergency services. But you do have flexibility to provide other services beyond just the emergency services. Rural emergency hospitals are allowed to maintain off-campus provider-based and rural health clinics. And it is our understanding that rural health clinics that might have a grandfathered rate specific to the cost, that the change that happened, I believe as of that date, December 27th, that actually capped cost-based reimbursement rates. To the extent you have a rate that is being grandfathered specific to that rural health clinic, you are able to keep that grandfathered rate as a rural emergency hospital. Um, Also, the rural emergency hospital can provide other ambulatory services, post hospital, and can post hospital services, and can also maintain a distinct part skilled nursing facility. It does, according to our read of the current statute and regulations, a skilled nursing facility is the only distinct part unit that a rural emergency hospital is allowed to maintain at this point in time. So certainly specific to the payment rules, while there are enhanced payments for rural emergency hospitals, there are also things that the REH must give up in order to qualify that can have negative revenue impacts. So certainly the gains are, a 5% fee schedule bump for anything that's paid on the outpatient prospective system, the OPPS. It's the fee schedule plus 5% for Medicare fee for service. So even the critical access hospital, they would convert from cost-based to fee for service reimbursement based on the fee schedule, but they would experience a 5% bump in the reimbursement. And then in addition to that, there is the fixed facility payment of $3.2 million per year that would come forth from CMS in exchange for either cost-based reimbursement or the current PPS. This would replace the fixed facility payment as well as the enhanced outpatient OPPS fee schedule with the 5% bump would replace current fee-for-service, PPS fee-for-service reimbursement or cost-based reimbursement for the critical access hospital. In order to gain that revenue, the things that we know that hospitals have to give up currently is certainly close inpatient services for all payers. So this is a Medicare fee-for-service program at this point in time. But certainly, as you look to transition, the licensure status from either PPS or critical access hospital, that would be done for all payers. Also, you would need to close swing bed services and shift that to either another owned entity. Maybe your organization already owns a skilled nursing facility. Certainly, you could transfer those swing bed patients to an unowned skilled nursing facility because the rural emergency hospital is allowed to keep that separate and distinct unit. So either transfer to an existing facility in the community, owned, or maybe a third party skilled nursing facility, or you could consider the creation of a distinct unit as a rural emergency hospital if one does not exist. Transparently, we do not necessarily see that as a viable path forward for most rural hospitals to have the wherewithal to create a separate and distinct skilled nursing facility in the community. But certainly, current rules will allow you to do that. It really becomes a feasibility for the rural hospital to be able to do that. And then certainly the rural emergency hospital is not currently eligible for 340B drug pricing. And that is just a matter of statute that the rural emergency hospital is not recognized in currently 340B statute as an eligible provider. And so that statute would need to get changed in order for the rural emergency hospital to receive the 340B drug pricing benefit. As it relates to conditions of participation, certainly just high-level overview in comparison of the rural emergency hospital's conditions of participation in comparison to what current COPs or PPS hospitals currently might be functioning within. So this simply high level is identifying the categories, stating what the rural emergency hospital rules state, and then identifying if the REH rules are similar to either the critical access hospital conditions of participation or the prospective payment systems condition of participation. So, specific to emergency services, you can see that REH's COPs are very similar to both PPS and critical access hospital. Current COPs, staffing and staff responsibilities, very similar to the critical access hospital, but slightly different for PPS hospitals specific to advanced practice clinicians. Nursing services are very similar, but without any inpatient requirements in comparison to both the CAH and the PPS. And certainly discharge planning, very similar to the current rules in both the critical access hospital and the PPS hospital. For deep dives, I'm certainly giving you the links here and pointing you to where the full conditions of participation can be found, but again, giving you these high level comparisons. Similarly, on this slide, comparing laboratory and imaging, the REH rules are very similar to the critical access hospital and the PPS hospital. The current operating environment. Quality assessment and performance improvement, again, very similar to what both PPS and critical access hospitals would be experiencing to date. Infection control and pharmacy, again, both very similar. So again, for more information, we have provided the links within the slide deck specifically to show you where to go and do a deep dive. And certainly if you have specific questions, we are here to answer those questions as well. Specific to the rural emergency hospital enrollment, the following, should be describes, not descripts. Forgive the typo on the slide. At a high level, the enrollment process, as well as what converting back, the flexibilities to convert back if deemed necessary. And so, we are being told that the application is a CMS 855 change form. It's not a new application, but it is a change in application. It's our understanding that the PAYCO system is set up to accept these applications. But I did hear just yesterday that there might be a technical issue for PPS hospitals that is being sorted through right now. If there is interest in submitting an application, that's up and ready to go, but there was a technical issue identified for PPS hospitals that is being remediated. Screening that's subject to limited screening, similar to CAH and PPS rural hospital current screening requirements. The enrollment status is effective on the date that the state agency CMS or CMS contractor survey is completed. And again, this is an area just in the spirit of transparency we are working through because CMS does not require a certification. So sorting through what that actual communication is backed to the MAC as it relates to an effective date. This is one area where additional clarity is still needed as it relates to the effective date of the official enrollment. And then the RH status remains effective unless a hospital elects to convert back to either a CAH or a PPS, or the secretary determines that the facility no longer meets the REH requirements. Specific to converting back, certainly there is flexibility to revert back to either become a critical access hospital or a PPS, but that conversion back would be a new application. And so it's where this, conversion to the REH is a change. Converting back would be a new application or an initial enrollment application. And we do want to point out that critical access hospitals that have that designation because of necessary provider designations or flexibilities that were made available many, many years ago, that those critical access hospitals cannot transition back as CMS guidance is put forth right now, or regulation as it stands today, because that flexibility to be a necessary provider designation no longer exists. And so this is one area that we are asking for CMS clarification, but is our understanding that a necessary provider, critical access hospital, cannot convert back to a critical access hospital if they would so choose to become a rural emergency hospital. That conversion back to a critical access hospital is not available to them as it stands today. What the application process, again, this is just a high level overview of what the application process could look like. Again, our technical assistance center is prepared to help guide you on this journey. In terms of getting to the application, supporting that application submission. And then this is the flow chart of what needs to happen or what would happen after that submission as it relates to completion of review, and then ultimately reaching an approval or denial specific to that status. And then, identifying the effective date of when that new payment mechanism would become effective. So as you can see, the yellow box on this is really specific to the state and what is going on in the state. And that ties back to the point I made earlier that states' preparedness for this and the work that needs to happen at the state level will ultimately determine, how quickly somebody can convert to a rural emergency hospital. Also, pointing out that there will be a quality component specific to the rural emergency hospital. There will be a program, but as of yet, that has not been published, and so more detail to come. But we do know that the proposed measures align with the critical access hospital quality reporting requirements and are really awaiting final approval. We also know that rural emergency hospitals will be required to file cost reports similar to what critical access hospitals are required to do. And we also know that for calendar year 2023, rural emergency hospitals, there would be no new reporting or data collection requirements related to the rural emergency hospital monthly facility payments. So certainly awaiting further clarification in terms of what transition planning requirements will be, as well as what types of information the rural emergency hospital will have to put forth to really document how they are using that fixed facility payment for the benefit of the community. So that's really a high level overview of what the REH is. And, certainly if you have questions, happy to entertain them. But I do want to spend a little bit of time just talking about the specific technical assistance that we're, teed up to provide to you. Certainly I touched on this on earlier slides as we went through the slides specific to our approach, but just want to highlight a little bit more specific information here. So certainly, as stated, we are facilitating a process that starts with education and then moving through and doing performance or financial assessments to identify what the new REH designation might mean for you for hospitals where it makes sense. So through some initial assessments, we gather some high level information that identifies if conversion is even feasible. And if we think that a conversion could be feasible, then we do the financial assessment and really fine tune the financial assessment. For hospitals that are looking for it, we also then will provide strategy and planning technical assistance to identify if there's things that should be or perhaps maybe would produce a better outcome for the community specific to service provision, providing that technical expertise, and then certainly supporting the application process with the overall goal again of retaining access to high quality healthcare in rural communities. This is really just a different example of I would say the process flow. And so it really is a phased approach of technical assistance. So certainly we start with engagement, education, intake forms, and then an initial meet and greet to learn a little bit more about each organization. If we identify that there is then the need for financial modeling, if it makes sense to move to the next step, certainly would ask the hospitals to complete an additional questionnaire that would have some financial information, which then triggers the work specific to developing the modeling tools to show hospitals what the new REH designation could produce for them. Then again, if they're still interested in pursuing, understanding that the math does work, then we would move forward to phase 3, which is application support as might be needed. And then again, transitional and strategic planning would be phase 4. Once the conversion is made, is there work that we could do maybe from a strategic planning accountability perspective that could actually help you, easily transition, or I don't want to say easy, but make the transition from either the PPS or CAH to the rural emergency hospital. So it's a phased approach, and certainly wanting to provide technical assistance through the conversion process where it makes sense to do so. This is also an engagement and enrollment timeline. So again, we do plan on working with 2 groups of hospitals each year. So if you don't feel like your organization, maybe you think it could be something you want to do at some point, but you're not quite ready for that, that is certainly okay, because we will be looking to enroll or onboard hospitals twice a year and then lead them through this structured process that I just described. And so, currently our work is anticipated to be for 5 years. And so certainly we anticipate working with, various cohorts or various groups of hospitals over the next several years to guide them through this process when it makes sense to do so. So if you're not quite ready, but think you may want to consider this at some point in the future, certainly there's going to be opportunity to reach out to us at a later date and time, and we would then roll you into the cohort process that would be underway or would make sense at that time. The other thing that we are developing, as I also mentioned a couple of times, is various financial modeling tools. And really, the starting point for that is understanding your baseline, understanding your current starting point within the either critical access hospital or PPS framework right now. And so really we start with a revenue summary that looks to understand your baseline, your current existence, as well as model that into the future using some general assumptions. And then layering onto that what an REH conversion could look like, specific to cost changes, service line changes, as well as the revenue changes. And then layering onto both of those future trends specific to market basket adjustments, utilization changes, etc., based on input from all of you, as well as then changes to your cost structure. So we certainly recognize as rural hospitals, I think there's a false assumption that all inpatient costs would automatically go away. We certainly recognize that oftentimes, it's the same staff providing inpatient and observation services and all of that. And so also we recognize that with the conversion, you could also be deploying staff to other areas of the hospital, especially given, the staffing crisis that everyone's facing today. But really building a tool is our goal that will allow for scenario planning, to actually scenario plan and move buckets of money as part of this modeling that will give you hopefully a future picture of what an REH conversion could look like for your organization based on input from each individual organization and customized to each individual organization and community. We also have developed a number of additional resources that would aid you in this conversion. So we do have a digital handbook resource guide that should hospitals be interested in, joining us on this exploratory journey, resources to guide you along the way. We would be asking all of our hospitals as well to sign a confidentiality agreement. One of the things that we guard very closely is confidentiality of hospitals that reach out to us for technical assistance. One of the things that we are looking to create is what we call cohort-based affinity groups, where we would look to bring together hospitals that are on the journey at the same time together, to produce a shared learning environment with hospitals that are maybe considering the same type of conversion, again, just for shared learning. But as a result of that, we do recognize that hospitals that join us on this journey would also see who else is on the journey, and certainly would be asking everybody to guard that information, through confidentiality and non-disclosure agreements, because we want everybody to have the freedom to make this assessment without any undue external pressure. Certainly, there's articles being published out there. This rural emergency hospital is getting media attention, and certainly we would not want, a hospital's information disclosed to the media if they wanted to keep it confidential. That's the reason we feel a confidentiality agreement is very, very important, to just make sure that everybody, guards the information that they would potentially see as part of this journey. We also have a number of resources that are available on our website. Even as of today, there are REH resources out there, including a frequently asked question document, an RH fact sheet, application instructions, as well as the recordings from our webinar, as well as our slides from last week. So all of that is already out there, and we're making that broadly available. So if you want to learn more, have questions, certainly feel free to go to our website, review the FAQ document, and if you still have questions that aren't answered, you can always send us an email to the support line, even if it's just a question for clarification. We're more than happy to answer that. So today, just providing insight into what the, I'm going to say, identified conversion barriers have been. This is reporting as of January 15th. It's very, very real time, as every day we get outreach from other organizations. But certainly the 340B revenue for the critical access hospital has been identified as a barrier, as well as the loss of swing bed revenue. But also specific to swing bed revenue, swing bed is not only the revenue that the critical access hospital may have to give up, but there are some communities that have no other skilled nursing alternative in the community. And so that has been identified as a barrier. Areas where we know that there needs to be CMS clarification, obviously the transition plan specifications, the final rules, OPPS rules that were put out basically identified and stated that transition plan requirements and specifications would be forthcoming in future rulemaking. And so we don't know what that looks like, and are waiting for clarifications on that. Specifics on the quality requirements for the rural emergency hospital. Again, we're awaiting that. There's question regarding, the REH impact on Medicare Advantage. So we know that many states have a high prevalence of Medicare Advantage in the state. And so really trying to understand if there's going to be any CMS requirements from a Medicare Advantage perspective for the rural emergency hospital, whether that's, enhanced payment, fixed facility payments, or any of that. Our read of it right now is that there are no expectations, but certainly are seeking CMS clarification on that. Also teeing up the protection for the necessary provider critical access hospitals to convert back to a CH after REH designation. So again, that currently does not seem to be allowed because of that necessary provider designation option no longer being available at the state level. And so asking for CMS clarification on it. And then also consideration for Indian Health Services. This is another area that the final regs basically said would be addressed in future rulemaking. Legislative considerations. So, consideration for frontier extended stay clinics to become REH, which is similar to the next one. The next item is, there are some states that have had their rural hospitals actually convert to outpatient campuses of larger organization in order to keep healthcare in the community. They just became part of a larger organization and converted to outpatient campuses, and by doing so, gave up their CCN. And so therefore our read is that they do not qualify for rural emergency hospital. We believe there's work to be done to qualify rural emergency hospitals to be allowed to have other distinct units besides skilled nursing, such as, geriatric psych units and inpatient rehab distinct units, et cetera. And then working, or trying to get some flexibility specific to that December 27, 2020 bed size reductions for hospitals that may have reduced bedside after and would meet that calculation as of today, but did not as of December 27th. And then certainly the REH eligibility. So this is a snapshot in terms of the barriers that we've identified and where we believe more conversation is needed in order to have hospitals be able to take advantage of this designation. um, Sharing with you the resources that we have available. So again, our website, and on our website we do have links to some of the other documents as listed on here, and then also just giving you the internet addresses of some of these documents if you would like to get more information. Finally, if you think this is something you're interested in, we are just an email away. We've provided a QR code that will take you to where you need to be in order to send us an email to get connected to us. But certainly, if you visit our website and go to the Rural Emergency Hospital Technical Assistance Program, you can get connected to us very easy. Should you have questions or think this might be worth investigating, please don't hesitate to reach out to us. That's what we're here for. So, Lara, that concludes my formal presentation, and certainly happy to entertain any questions that your audience may have or that you might have at this time.
Thank you so much. Everyone has the opportunity. You can unmute yourselves, or if you want to put something in the chat, I'll be watching that as well. Well, I'm not seeing any questions at the moment. Thank you so much for your time. If we do have questions that come up afterwards, I'll be sure to reach out. Also, if anyone on this call or is watching the recording would like to be placed in touch with the Rural Health Redesign Center, please let me know. I'm happy to make that introduction. Thank you again, Janice, and everyone have a great day.
You as well. Thank you.